Good morning, everyone. Myself, Dr. Sharwani, pediatric dentist. Today, I'm going to discuss you about a small topic that is pediatric endodontics. Before going into topic, I would just like to thank Cynodent members for giving me this opportunity. So, coming to content, which includes the introduction and differences between primary and permanent teeth, how to diagnose the pulpal changes in children, results of endodontic treatment, pulp therapy, followed by conclusion. So, initially, what is the difference between primary teeth and permanent teeth? There are almost 12 differences between primary and permanent teeth, but the main difference is the distance between the occlusal to pulp chamber in primary teeth is very less, that is about 2 mm, rather than the distance between the occlusal surface to medial horns, that is pulp horns in the permanent teeth. As a result, even a small cavity in the primary teeth may lead to involvement of pulp during cavity preparation or any decay. Small decay also may lead to pulpal changes in primary teeth. So that is what we'll go for a radiographic diagnosis in children, followed by clinical diagnosis also. A radiographic diagnosis is very important in the primary dentition rather than that of the permanent dentition, because the child cannot localize the pain and he cannot exactly say the features associated with the pulpal changes. So both clinical diagnosis and radiographic diagnosis helps us in coming to treatment options. Coming to what are all the various treatments that we undergo in the pediatric endodontics. That is, initially, the pulp therapy in pediatric dentistry can be divided into two types. That is vital and non-vital. Again, the vital is divided into three types. Pulp capping, that is direct pulp capping, indirect pulp capping. Coming to pulpotomy and pulpectomy. Coming to non-vital pulp therapy. The pulpectomy usually comes under non-vital pulp therapy and apexification and apexogenesis. These are broadly categories that we divide into pediatric endodontics, that is vital and non-vital. Coming to vital, which includes pulpotomy, direct pulp capping and indirect pulp capping. Coming to non-vital, it includes pulpectomy, apexification and apexogenesis. So, what are the goals of pulp therapy? It includes, primary teeth are very useful for the children because they play an important role in preserving the arch dimensions. And at the end age, that is the anterior in the primary dentition, helps in aesthetic purposes. Loss of primary teeth, that is anterior mostly, may lead to problems in aesthetic problems, whereas speech problems, and loss of posterior, which may lead to complete arch discrepancy, which may lead to crowding in permanent dentition. So preservation of each and every primary teeth is important. Hence, the pulp therapy includes the main goal of the pulp therapy is preservation of primary teeth to maintain arch length. Yeah. And it helps, as we have discussed, it helps in speech, phonetics, and ability to speech, and prevents the abnormal habits also. Coming to diagnosis, how we are going to diagnose the primary teeth? As initially we have said, both clinical diagnosis and radiographic diagnosis are very useful for any pulp therapy treatment. First thing, and also the main key role is the length of the time where the tooth is to be present in the oral cavity. Suppose if the child is higher of age is 5.5 years, where his primary incisors has been decayed. So in such conditions, if there is no use of saving the primary incisors, we can extract it. Otherwise, if the child is 3.5 years, where he has severe decay of primary incisors, then we are going to do the pulp therapy. There is a lot of difference here. The length of the time where the teeth is to be retained in the oral cavity is also the main key role in the diagnosis of the treatment plan. Second, health of the patient, resorption of the tooth also. You see, any pulse therapy, either it may be pulpotomy or whether it may be pulpectomy. More than 2/3 of the root must be present in order to do a pulpectomy or pulpotomy or any treatment related to pulpal pathology. Coming to clinical assessment, how are we going to assess the clinically? It is a very toughest assessment that we are going to do in children because they cannot explain exactly what is going to happen in their teeth. We just will just ask the questions according to their way. That is, whether you are getting any pain while eating the ice cream or whether it is hurting you while drinking any hot milk like this. Whether you are unable to eat it or whether you are unable to swallow it. These are all the clinical assessments that we are going to ask the children. Coming to radiographic assessment. Yes, see, radiographic assessment, most important, that is, we are going to see the any pulpal pathology, that is inflammation, whether the caries is involving pulp or not, because the pulpal hearts are very high in the primary teeth rather than that of the permanent teeth. And see, where most of the like lesions are involving the bifurcation areas or trifurcation areas. It is the most common cause for the cyst or granuloma in the children. So, the radiographic assessment is that much of important. Just the patient is having the pain, we are going to do the pulse therapy and completed its fast. The radiographic assessment should be there before we are going to start any treatment plan. Now, next, coming to vital pulse therapy. It includes three. We know that pulpotomy, indirect pulse capping, and direct pulse capping. These are three which are going to include in the vital pulse therapy. So, here, it has a high healing capacity of the pulse. It is initially it is removing the local irritant and protecting the pulse by placing a suitable material. The primary goals of vital pulse therapy are two, mainly basically formation of dentin bricks and continuation of root development. Now, followed by next one, coming to direct pulse capping. So, direct pulse capping and indirect pulse capping. What is indirect pulse capping? It is a procedure where the non-remineralizable carious tissue is removed and only the amount of the tissue is removed, whereas the deepest layers of pulp is kept intact. They think that these pulp has the capacity to regenerate and it makes the tissue healthy, pulp tissue healthy. According to the models like McDonald's, it is grossly removed. The caries is grossly removed and placement of a suitable biocompatible material. What are steps and what are the objectives involved here? So indirect pulse capping includes first arresting of the caries process. Next, helps in the dentin protection of dentin, followed by formation of tertiary dentin and remineralization of carious dentin. So what are all the indications? Which includes a mild discomfort. Next, absence of nocturnal pain. See, if the patient complains of nocturnal pain, blindly go for pulpectomy. There is no other option. If he is complaining of nocturnal pain, blindly go for pulpectomy. That is pulpectomy. Now, clinical examination. There will be the caries that there will be the absence of pain in the lymph nodes or the tooth will be appearing normally. Radiographic examination includes there is no radiolucency, that is in the percussion area. Coming to contraindications. What is the contraindication? Absolute. If there is any sharp pain, then it is contraindicated. Okay. Next, coming to clinical examination. The tooth, if there is any of mobility, then it is contraindicated for indirect pulse capping. So, procedure. What is the procedure? Initially, for any whether it may be vital pulse therapy or non-vital pulse therapy, we are going to administer local anesthesia with Rapadam. Isolation is must and should. Okay. Next, you are going to remove all the caries that is injected dentin and everything. Later, the cavity is right. Next, we are going to place the calcium hydroxide filled with zinc oxide used as cement. This is the procedure. And now, after there should be the recall checkup. So initially we'll remove all the caries. We'll remove with a small round bud, followed by removal of caries with a small spoon excavator, followed by placement of the medicament. After 2 to 6 weeks later, that is 6 to 8 weeks later, that is remove the temporary zinc oxide used and check for any dentin bridge formation. How would we check the dentin bridge formation? By radiographic assessment. And next, place the permanent restoration. That is zinc CIC. Followed by placement of stainless steel round. Now, coming to having the time, that is 6 to 8 weeks time. So, first, what are all the histopathological changes that takes place during the 6 to 8 weeks time? So, initially, first 30 days, tubular dentin will be formed. Later, cellular dentin. Next, globular dentin. After 3 months, that is after 8 weeks or 9 weeks, 0.1 mm of tubular dentin will be formed. This is the outcome of indirect pulse capping. So, a gross review of indirect pulse capping. What is that? Removal of the caries. Okay. Deeper layer of caries is left behind, and removal of caries. Placement of the suitable medicament like calcium hydroxide, followed by temporary restoration initially. Later on, after 6 to 8 weeks, what we are going to do? We are removing the temporary restoration and place the permanent restoration, followed by crown, stainless steel crowns. This is the overall outcome of indirect pulse capping. And coming to direct pulse capping, here what's the difference between the direct pulse capping? Here in direct pulse capping, when we are removing the surface caries, we mechanically, unfortunately, sometimes the pulse may be exposed. During that condition, the pulse is covered with a layer of suitable medicament that is called as direct pulse capping. Okay. And that medicament may be the calcium hydroxide. Coming to the procedure, as we have already said, this accidental or sudden exposure of pinpoint exposure of pulse, that is less than 2 mm, or sometimes during the anterior fracture of anterior, pinpoint exposure will be seen. In such conditions, direct pulse capping will be done. That is preparation of during the preparation of cavity, followed by placement of suitable medicament that recall the patient. And you see, for this pinpoint exposure of pulse, sometimes we may require vitality test also. But the vitality immediately doesn't work. It works after 2 to 3 weeks. Initially, what we are going to do is we'll place the medicament. So, what are all the contraindications for the direct pulse capping? History of severe pain during night, absolutely wrong. Next, that is contraindicated. Excess mobility, they will listen to state. As that of indirect pulse capping, same contraindications will be applicable for direct pulse capping also. Coming to technique, the rubber dam placement followed by local anesthesia, followed by rubber dam placement. Once the exposure is avoided, irritate it with saline, followed by stop the hemorrhage, place the suitable pulse capping material, and followed by final restoration. Next, and the main controversy that is going on is why the direct pulse capping is contraindicated in the primary teeth. Because initially they have said the localization of infection is very poor in primary teeth rather than that of permanent teeth, because the pulpal horns are very high in primary teeth rather than that of the permanent teeth. And Incidence of reparative dentin formation is very high in primitive rather than that of the permanent teeth. And the most is the cellular content, that is the primary pulp response is very high rather than that of the primary teeth. Due to these three reasons, the direct pulp capping is contraindicated in primary teeth. Next, what are all the features of pulp capping? Dentin ridge formation, maintenance of pulp vitality, lack of pain, minimal pulpal response, lack of internal resorption. Next, as there we have seen, what is that? In the indirect pulp capping for 7 days, the tubular dentin will be formed. After 8 weeks, that is after 3 months, 0.1 mm of tubular dentin will be formed in indirect pulp capping. Coming to direct pulp capping, after 24 hours, necrotic zone of calcium hydroxide is formed. After 7 days, there is an increase in cellular and fibrillary activity. Next, after 28 days also, here also same. There will be the zone of dentin. There is 6 to 8 weeks. Here, which is 28 days. You will be getting some of the new dentin. Next, what are all the various pulp capping agents? There are numerous number of pulp capping agents. This is one of the 4 marks question for you in regarding the pediatric endodontics. What are all the various pulp capping agents? So when you are going to attend this type of questions, we are going to write the definition of direct pulp capping, procedure of pulp capping, indications and contraindication, then followed with pulp capping agents. So that is zinc oxide usual, calcium hydroxide, GIC, biodentin, MTA, propolis, stem cells, enzymes, and growth factors. These are all the different types of pulp capping agents which you are going to place in the direct pulp capping. Coming to what are all the ideal requirements of pulp capping? That is, it should be radio opaque. It should maintain the pulp vitality. It should induce the reparative dentin formation. It should induce the fluoride releasing agents also. It should be bactericidal and bacteriostatic both. Now coming to major subject, that is pulpotomy. Basic major subject in this pulpotomy and pulpectomy in the pediatric endodontics. What is pulpotomy? According to Finn, complete surgical removal of entire coronal pulp, leaving the vital radicular pulp within the canals. So what are all the indications? Mechanical exposure, large carious lesions, but free of radicular pulpitis, no spontaneous pain, no abscess, no interradicular deficiency. As we have said, 2/3 of the root should be present. Next, what are all the contraindications of pain? Root resorption more than 1/3 and uncontrollable bleeding. Main hemorrhage. Control of hemorrhage is one of the most deciding factors whether you are going to do pulpotomy or pulpectomy. Okay. Next, pulpotomy according to Ramlet. See, listen, according to Ramlet, it is divided into 3 types. That is, revitalization, preservation, and regeneration. See, again, pulpotomy is divided into vital and non-vital pulpotomy. Vital pulpotomy again divided into 3 types, which includes revitalization, preservation, and regeneration. Non-vital pulpotomy includes mortal pulpotomy. This classification is very, very important while you are going to attend the pulpotomy answer. It is basically due to 9 marks answer for you for the final year going students and even the people who are preparing for NEET also. This is the question where they are going to ask. Among pulpotomy, there are various types of pulpotomy techniques, that is cormophysial pulpotomy, ferric sulfate pulpotomy, laser pulpotomy, next glucan head pulpotomy, each and everything. But each pulpotomy has their separate success rates. But majority of the clinicians now they are doing cormophysial pulpotomy, which is 4 minutes. And recent advances include 1 minute pulpotomy also. Please engage with 4 minutes pulpotomy or 1 minute pulpotomy. Both has equal success rate. Then what's the point of doing 4 minute pulpotomy? Rather, we can go for 1 minute pulpotomy also. Okay. The histological changes will be same both in 4 minutes pulpotomy and 1 minute pulpotomy. So now coming to form of result pulpotomy. So what is the composition of form of result? This is also important bit. Result 35%, glycerol 15%, formaldehyde 19%, followed by water 13%. It was given by Buckley. The word pulpotomy, that is form of result pulpotomy, was initially given with sweet. Preparation. We are going to place 1/5 of the Buckley's form of result. Okay. In which you include 3 parts of glycerin, 1 part of water and 1 part of form of result. That is 1/5 of the form of result. You are going to dilute the form of result. So what are all these steps? As usually, we will place the local anesthesia followed by rubber dam, removal of the caries with a small round bag, opening of the access cavity with the endosed bag, followed by irrigating with the saline, removal of the pulp horns of the coronal pulp, removal of the coronal pulp with the help of small spoon excavator, followed by irrigation, followed by placement of 4 minutes or 1 minute form of result. See, technically, according to your textbook, you have to write 4 minutes, but clinically, you can do 1 minute pulpotomy, form of result pulpotomy also. Okay. Next, fill the pulp chamber with the antiseptic paste and then tooth is restored. Now, how this pharmacology is going to act? This pharmacology causes the coagulation necrosis. That is, it kills the, it stops the hemorrhage, and it's a removable process. Okay. Next, what are all the histological changes? Immediately, see, 4 zones will be seen. 4 zones of pharmacological fixation will be seen. First, initially, zone of fixation. Next, zone of atrophy, zone of inflammation. Remember is that FAI. That is fixation, zone of fixation, zone of atrophy, zone of inflammation. These 3. Okay. Next, the disadvantage of the pharmacology is after 1 year, there may be chances of pharmacology entering into root chambers. Next, everyone has some of the side effects. That is, the pharmacology also have few side effects. That is, immunological risk. Like, next, it is highly toxic. It blocks the RNA. It depresses the matrix synthesis. These are all the effects of pharmacology. Hence, we are diluting the pharmacology to 1/5%. Coming to 2-visit revitalization pulpotomy. See, if there is any slight bleeding, or if there is any pus in the coronal chamber, then you are going to do for 2-visit pulpotomy. Okay. Next, what are all the materials used in 2-visit pulpotomy? That is triglycerol, glycerin, and elastic formaldehyde paste, paraform formaldehyde paste. Okay. And then, initially there in the single visit pulpotomy, we are directly going to place the suitable medicament and we are going to close the teeth. Okay. Here in the 2-visit pulpotomy, you are going to place a temporary restoration, and after, that is in the second visit, you are going to again remove the temporary restoration, and you are removing the old cotton pellets, filling the cavity with saline, and now the chamber is filled with antibiotic paste. That is the difference between single visit and 2-visit pulpotomy. Coming to glutaraldehyde pulpotomy, electrosurgical pulpotomy. See, here form of result, you are going to use 1/5 of the Buckley's form of result. Next, in the glyceraldehyde, we are going to use only 2% of the glyceraldehyde. Next, coming to electrosurgical pulpotomy. This is also this is not important up to the final year status, just mention the name. Electrosurgical pulpotomy. It was given by Mark. And coming to laser pulpotomy. Here the Nd:YAG laser is used for the case of pulpotomy. Next, now materials of pulpotomy. There are various materials that are used as a pulpotomy agents. See, pulp capping agents are different and pulpotomy agents are different. Pulpotomy agents initially, nowadays, the broadly used material is zinc oxide eugenol, which is used as a preservative and pulp sedative. That's the reason where we are going to use pulpotomic agent, that is zinc oxide eugenol as a pulpotomy agent. Now, this is the glyceraldehyde for pulpotomy. We have the 2% of glyceraldehyde is used for the as a pulpotomic agent, just like formoprizole. Same as formoprizole, it also acts as a rapid fixation. Here we remember FAI, that is fixation, atrophy and inflammation. Here, the zone of eosinophilic zone is seen. Next, what is the advantages of glyceraldehyde over formoprizole? It is bactericidal. It has a limited penetration. It causes less necrophiles. Next, ferric sulfate pulpotomy. These are all the techniques and different. See, pulpotomy, you can place the formoprizole to stop the hemorrhage. You can place the glyceraldehyde, you can place the ferric sulfate. These are all the materials that are used to stop the hemorrhage. Okay, coming to pulpotomy materials like zinc oxide eugenol. It is the agent like after control of hemorrhage, we will place the zinc oxide eugenol. Okay. Each and everything has an individual success rate. The ferric sulfate also has the individual success rate. That is 100% success rate during a 12-month follow-up, according to this T et al. Author. Now, coming to calcium hydroxide pulpotomy. As usual, it was given by Zander et al. Here the histological changes include superficial portion of the pulp. Next, after 4 weeks, there is a development of new odontoblastic layer. Twist pulpotomy. This is the pulpotomy that is seen in the end permanent teeth. It is supposed to be trick. Where see any like impermanent like traumatized teeth, where there is the exposure of little exposure, that is more than 2 mm of the exposure of pulp, then in such conditions we are going to do the thread pulpotomy. Next, MTA pulpotomy. It is an agent, that is after completion of placement of formoprizole or any ferric sulfate, that is after obtaining of hemostasis, we are going to place the MTA instead of that zinc oxide eugenol. We are going to place biodentine instead of zinc oxide eugenol. Okay, these are all the studies where they have shown that the MTA or biodentine also plays an important role for the as a pulpotomy agent. Next, bone morphogenic protein. It has the capacity to induce the reparative dentine. Okay, and scientists et al. Have concluded that these bone morphogenic protein have the capacity of auto-induction of pulp and preserves the radicular pulp, that is maintains the vitality of the pulp. Now coming to non-vital or mortal pulpotomy. See, pulpotomy is divided into two types, mortal pulpotomy, that is non-vital pulpotomy, and vital pulpotomy. Vital pulpotomy again divided into various types, that is single visit and two visits, which includes devitalization, preservation, and regeneration. Among regeneration, one morphogenic proteins. Among devitalization, you will come across ferric sulfide or zinc oxide eugenol. Again, under preservation, you will be getting about ferric sulfide or surgical laser pulpotomy. Coming to non-vital or mortal pulpotomy, the material used here are Beeswood cresol or cormocresol. When are we going to do this technique? This technique is carried when the inflammatory process affecting the coronal pulp extends to radicular pulp, leading to an irreversible damage to pulp. Here, the necrotic coronal pulp is removed. The pulp chamber is irrigated with sunlight and then dried with cotton pellet. The infected radicular pulp is placed with the cresol. You are going to place the temporary cement for 1 to 2 weeks, followed by placement of stainless steel in the second appointment, that is removal of temporary cement, followed by stainless steel drum. As we have said, newer materials of pulpotomic agents, that is propolis, sodium hypochlorite, bioactive glass, plasma-rich plasma, pulpotec, and biodentin. These are all details. There is no need for you people. Just mention the pulpotomy agent, that is LFK. Coming to the major procedure, that is pulpectomy, that is complete surgical removal of infected pulp from the root canal of the primary teeth, followed by placement of an inert restorative material to maintain the teeth in dental arch. So, see, the children, basically the students, will get confused between pulpectomy and root canal treatment. What is the major difference between the pulpectomy and root canal treatment? Pulpectomy, it is done in primary teeth, whereas root canal treatment is done in the permanent teeth. Here, in the pulpectomy, you are going to place the inert material, that is resorbable material, whereas in the root canal treatment, you are doing a non-resorbable material, that is gattapacha. Your most regularly asked viva question is, what are the materials used for pulpectomy? That is materials, that is Metapex or Vitapex, Endofloss, zinc oxide eugenol, okay, carrot paste. Gattapacha is not the oxydating material that is used for permanent teeth. It is primary teeth. Gattapacha is always a non-resorbable material that is used in permanent teeth, not for primary teeth. Gunshot viva questions or else MCQ in the upcoming NEET appearance. Okay, coming to root canal filling materials. It should be resorbable. It should be like what we said, radio opaque. It should be antiseptic and it should not shrink. It should not discolor the teeth. It should not affect the surrounding periapical tissues. Okay, coming to zinc oxide eugenol. It is the gold standard material we are going to use for the material. Okay. And there is no need of composition for the calcium hydroxide, but the placement of calcium hydroxide is very easy, and it is an oily material that cannot be removed easily from the root canal, but it resorbs rapidly rather than the resorption rate of root. Okay, so the calcium hydroxide is mostly used in the resorption cases, like where the teeth has mostly in the primary teeth, but in the cases where the infection conditions where there is a swelling. In those conditions, it acts as both antibiotic, that is antiseptic, and it also helps to protect the canals from future infections. It has no toxic effects to the permanent successor. And KRA paste, as you said, it is also one of the materials. Now, coming to, see, you have learned about various obturating materials, that is zinc oxide ethanol, endofloss. Endofloss is also the gold standard and upcoming material that is used in the pulpectomy, which includes the barium sulfate. The presence of barium sulfate use the radio opaque material for endofloss. Endofloss, zinc oxide ethanol, KRA paste, metapaste, and vitapaste. These are all the obturating materials used for primary teeth. And what are all the obturating techniques for pulpectomy? That is, major widely used technique is Reamer technique, followed by bidirectional syringe, insulin syringe technique, tuberculin syringe technique. These are the obturating techniques. If you get the question of pulpectomy, you are going to write the definition, indications, contraindications, obturating materials, obturating techniques. Obturating technique includes tuberculin syringe technique, Reamer technique, bidirectional syringe technique, insulin syringe technique. These are enough for your standard. Okay. Now, coming to apexogenesis. Apexogenesis is defined as a physiological root and development and root and formation. Okay. Means the formation of twigs root sheet which maintains the pulpal vitality also. Mostly apexogenesis is done in traumatized or pulpolingual permanent teeth with incompletely formed roots. There will be no history of spontaneous pain, no history of sensitivity, no hemorrhage. Contraindication includes urine discharge, no prolonged pain. Okay. Now, it can be regarded as teeth pulpotomy. Okay. See here, in the picture itself shows that is opening of the access, like up to where the exposure has been accessed, we are going to remove the caries. Placement of the suitable material, that is opening, access opening, followed by places of suitable material. Next, placement of crown, followed by follow for every 6 months. Okay. Apexogenesis means vital pulse, maintaining the vitality. Coming to apexification, here non-vital teeth. Okay. There is a lot of difference between apexogenesis, means you are doing in a vital teeth. Okay, apexification, non-vital teeth, but the similarity is both are having open end roots itself. Okay. So apexification. In here it is a process where non-vital immature, that is root formation is incomplete, where the root has lost the capacity for further root development. Okay. Then, the placement of medicament in apexification is calcium hydroxide. But the disadvantage of this calcium hydroxide is it takes minimum of 18 months for the formation of root closure. So, appointments will be heavy appointments, right? Next. See, coming to apexification procedure, initially you are going to do the access cavity. After entering into the access cavity, you will be removing the exposure pulp. After the exposure pulp, you will be placing the calcium hydroxide at the pulp, that is pulp orifice, coronal pulp orifice. Later, you will be recalling the patient for every 6 months or 12 months or 18 months. Okay. After that, we are going to check the root end formation. Okay. And there is one of the criteria where you are going to use in apexufication. That is Frank's criteria. Frank's criteria includes placement of it includes the different stages of root formation in the apexufication. The Frank's criteria includes 4 steps. That is continued closure of canal and apex. That is complete closure of root. That is the first step. Other second, apex will be closed, but root canal remains little bit larger. Third criteria of Frank's criteria includes no radiographic changes, but thin osteoid barrier will be formed. Fourth one, that is radiographic evidence of the barrier will be formed. Among all the 4 criteria of Frank's, the barrier will be formed, but there will be little difference. In the first one, complete root canal will be formed, whereas in the second one, root closure will be seen, but there will be no complete closure of root canal. That is third one. The barrier will be formed, but there is incomplete closure of the root. That is fourth. The root canal will be closed, but there is a little opening of root apex. These are all the 4 criteria of Frank's criteria. Whenever you are getting the question of apexification, you are going to write definition, followed by procedures, followed by indications, followed by these Frank's criteria also you are going to include, which is very, very important. Okay. And this is the disadvantages of calcium hydroxide as we discussed later. Coming to conclusion. So, see broadly upon gross conclusion, the vital pulse therapy is divided into 2 types, vital and non-vital. Vital pulse therapy includes direct pulse capping, indirect pulse capping, pulpotomy, and non-vital includes pulpectomy followed by apexification also, and apexogenesis also comes under vital pulse therapy. Now, apexification we have discussed the Frank's criteria, and along with that there are the recent advances in the apexification. Which includes revascularization. Okay, revascularization is the most important update, that is upcoming techniques in the apexification. You have just mentioned the name of revascularization. It's ends. Okay. These are all my references, and thank you.